Hello, everyone. Welcome to another Rafael Medina subspecialty virtual morning report. I'm very, very excited for today's session. I have a case presenter and a case discussant from my institution, and both of whom I've heard so many kind words about, and I can't wait to introduce. So, Dr. Albin is a neurointensivist at Emory and is famous for being an excellent clinician educator. If you don't follow her on Twitter, you have to close your camera, open Twitter, follow her, and come back. And has excellent tutorials, and actually, I just saw that has a book as well, and is famous for her educational qualities in general. Dr. Albin, you introduce yourself, and is it okay if I call you Casey?
Yes, absolutely. Thank you. It's great to be here. I'm really excited.
The question for the day is, how was your Labor Day weekend, and did you do anything fun?
Yeah, we went up to one of the lakes in North Georgia, and recently I just decided that I really would want to learn how to wakeboard. So I've spent like a lot of time falling, but it's been a lot of fun. Like gotten up a couple times, and then we taught my 6-year-old son how to wakeboard too, which is like really cool. So that was our Labor Day. It was a lot of fun.
That's awesome to hear. Sounds really fun. And then Sean Thompson is a PGY3 neurology resident. He's also, the moment I released the poster, many people told me, "Oh, Sean is so kind and he's so good at his work." He's also in the medical education track, which I was also a part of. Sean, do you want to introduce yourself and also tell us how was your weekend?
Hi all, I'm Sean. It's good to meet everybody. Really blown away by the turnout on this. So hopefully the stage fright won't set in. The Labor Day was excellent. I had to do some little administrative work in the morning, but after that I was able to take my cat in one of those little backpacks for cats around the block. So, and the weather was beautiful today. So it was great.
That's so sweet. I have two cats as well.
Perfect. I just have the one.
Yeah. If y'all are ready, we can go ahead and start with the case.
Absolutely. Should I just go ahead?
Yeah, you
hear
can
me?
go for
Okay,
it.
perfect. Well, the chief complaint is I can't see out of my right eye. The initial HPI, there's a 69-year-old male who is a cattle rancher. He was watching TV with his wife one evening when he slowly felt like he was in a daze. He looked over to his wife and realized he really couldn't see her as long as she was on the right side of him. He couldn't sense light or motion or anything in the affected area. And eventually, after a few minutes, the daze cleared up and he had no issues walking, moving his arms, speaking, but his vision remained impaired. So that's when he came to the hospital. That's the end of the first aliquot.
All right, great. So I can already say, 69-year-old guy. So I'm already thinking about things that would cause vascular conditions. So just kind of hearing, someone who's in their 6th decade of life, man, clues me into, okay, well, this is someone who's probably got some vascular risk factors. So that's sort of how I'm approaching it. Now, we haven't heard much about like his past medical history or what his social situation is, but that's sort of what I start to think of. And then we start to hear about this monocular painless vision loss. And so I think we'll probably get more details about what that is, but just when I hear someone describe the loss of vision in one eye with not associated with a lot of pain, I've put in my mind, okay, is this amaurosis fugax, which is a fancy way of saying, monocular blindness. And together with this, older gentleman who may or may not have vascular risk factor with painless monocular vision loss, I start to think about, could he have is this sort of like a retinal stroke? And so just hearing the story, the first thing that I'm sort of thinking of is, does this guy have a lot of plaque in his carotid? And do we need to get a CTA? And should we actually treat this, like had it not resolved and been like a amaurosis fugax TIA with, like something that would, like a TNK if this persisted. Now he comes with this daze, but daze is a really hard nebulous thing, so I don't know really what to make of that yet. But like something sort of like he didn't feel quite right, and he couldn't see out of one eye, He's probably got traditional vascular risk factors. Like I'm in my head sort of like, something's wrong with this guy's carotid. So that's how I would sort of start to approach it. Just hearing this like one little snippet.
Yeah, and it sounds like if a trainee is listening, the next thing you want them to do is ask about vascular risk factors and anything else you would want like trainees listening to this chief complaint to like how to approach the history if they just hear this portion.
Totally, yeah. So I mean, the tip though, he seems it sounds like it's pretty sudden. So we're starting to put this into the hyperacute phase of symptoms, right? But we do want to establish that it's actually hyperacute. You know, in neurology, we always talk about the differential is the time course and the localization. So we've talked a little bit about the localization of this being something in the, you know, the retinal artery and, you know, a branch of either a branch retinal occlusion or that he has actually had a stroke to the retina. So as the sort of localization that I'm thinking of from the start. And then we think about time course. So this sounds hyperacute, but I would certainly want to ask, like, has he had symptoms of this before? You know, he's a little on the young side for something like giant cell arteritis, which can also cause monocular blindness. But I want to ask, like, does he have headaches? Does he have any associated features? Has something been different recently? So those are some of the things that I'm starting to put together in terms of like, you know, vascular risk factors, time course, and any other accompanying symptoms, particularly headache.
Wonderful, thank you. And back to you, Sean. I don't know if you have all these answers or not.
Some of them. I will also point out, just for clarification's sake, the patient reports that this is monocular. So keep that in mind. It's the subjective report. So for our next aliquot, he did report a mild, just generalized headache, or mostly in the temples, but bilaterally. He also reports that about 3 months before, he started noticing intermittent tingling in the right arm. He described it like the arm was falling asleep. It was worst in the hand, but sometimes would radiate more proximally than that. Very occasionally, it was painful. When the tingling was at its worst, he also had trouble gripping small things. Strength otherwise in between these episodes felt normal, and sensation would go back to normal in between episodes. It did not seem to affect like one aspect of the hand more than the other. It seemed pretty much throughout the hand. And that's the end of, continuing this aliquot, remaining HPI. By the time that I was able to examine him, vision had not improved. This was several hours after the onset. The tingling in his right arm was active, and it was worse, he reported, when he uses it extensively. And it does improve with rest. Leaning his head against his right shoulder also seemed to make it worse. It does not relate to any particular time of day or overall body position. The tingling was not severe when the vision change started. Other general history, he has some hypertension, some GERD. He takes losartan, hydrochlorothiazide, omeprazole. He is right hand dominant. He is fully independent at baseline. Again, he is 69 and a cattle rancher, does not need any walking assistive devices. For review of systems, he had a mild headache in the temples, as noted before. The right eye was completely painless. He had no rashes, no recent coughing, sneezing, sore throat, diarrhea, nausea, no falls. Family history, his father passed away in his 40s from a very unclear lung disease, maybe mesothelioma. His sister died from blood clots after a knee surgery when she was in her 50s. Social history, he did quit smoking, but that was 40 years prior to presentation. Otherwise lives with his wife, remains active on the farm. He has no allergies. And that is the end of the aliquot.
Got it. Okay, so again, I'm still sort of thinking, could this, you know, is this a sort of vascular? This still feels vascular to me. The headache, again, a lot of people report headaches, so I don't really know how much to make of this. I don't really love this for some sort of vascular inflammation or inflammatory like vasculitis, but I guess I haven't ruled it out. What's interesting to me is that the hand numbness is associated with changes in vision. And when I'm hearing those two things together, I'm like, where could we localize this? And there is, you know, one way to do that would be, could he be deprived blood flow because of some subclavian steal syndrome. So that's one of the things that I'm sort of coming to think about. So when we think about that, though, so what's happening in subclavian steal syndrome is that because there is an occlusion in the proximal part of the subclavian artery, when the hand is active, that it can't get the blood flow from the typical aortic arch, right? So if you have the heart pumping out, it goes through the 3 vessels, and it's going into, on the right side, it goes, we have the innominate that goes up, and then you have the carotid branch, and then you have the vert branch a little further back. So what's a little bit hard about the right side is it has to be a very, very small amount of plaque, right? Because you don't have a separate subclavian artery on the right, unless you have some sort of abnormal configuration of the branches of the innominate, right? Or the great vessels. So that's a little strange to me. It's easier to do this when you have the subclavian artery on the left side, which comes off by itself, right? So the subclavian artery is branching off by itself, and then the vert is directly off of it. It's unfortunate that we can't draw this all out, because I feel like this is one of those things that it's very hard to mime how the great aortic branches look, but it would be easier if you have a proximal occlusion in the subclavian artery when it is by itself alone as a branch of the aorta instead of coming off of the innominate. But you still could, you certainly could have a very narrow occlusion between the innominate and then after the takeoff of the carotid, very small little, occlusion where you're still getting blood flow to the carotid, but you are prevented from getting good blood flow down the arm, and therefore are asking, basically demanding that blood flow in a retrograde pattern from the vert. So I don't think that that's impossible. It is a little weird that's on the right side. I do like that Sean gave us a little hint of maybe this really wasn't coming from the proximal, the anterior circulation with this self-reported, monocular blindness, keeping a broad differential that as students, we should remember that you have vision from the eyes. And so you can have monocular vision loss when you have something that occludes blood flow to the retina. Oh, look, we have a really pretty picture. Thank you, someone. So exactly. So you could still see, I'm going to go back to this little pretty picture here, that you could still have between, when the carotid's coming off and the vertebral coming off, you could still have a little in the subclavian, right basically here, some focal plaque. And he's an ex-smoker, but he was a smoker and he is in the sort of vascular risk factor. I'm still ooh, I really want to put this into vascular problems. Going back from this beautiful picture that we have to talking about localization from vision, we can have, we could localize it to the retina, and then all the way back along the visual tracts, to the optic nerve. Again, if someone had said that this was a 30-year-old woman who was presenting with painful monocular vision loss, I would have a totally different diagnosis or differential that would be much more likely to be something inflammatory like MS or NMO or even anti-MOG disease. But he's, again, not in that demographic. But going further back, then we get into the posterior circulation into the occipital lobes, right? And so you could sort of have a field cut or a homonymous hemianopia that sometimes people just say, I can't see out of the left, and therefore, get a little confused, and they basically are saying, I can't see things on one side, but they report it as the site of vision loss, right? So that is, we've all been there, and we'll have Sean tell us what he actually found on exam since this was still occurring. So those are some of the things that I'm thinking of is okay, so we could localize this into the anterior circulation with vision loss, or we could put this hand thing together with the vision loss and say this is all coming from a problem in the subclavian artery that is basically leading to ischemia of his arm. And again, Sean didn't tell us whether there was any sort of more specific sort of what part of the hand. So we're not thinking that this is a neuropathy of the hand so much as some sort of global hand phenomenon, which does sound to me very much like you could have like a radial artery occlusion or some other sort of problem getting blood flow to the hand, which would cause the whole hand to feel kind of numb and tingly and bad, right? So his demographics and just the co-occurrence of visual changes with hand and someone who's an ex-smoker just really makes me feel like, like we've got to get a CTA in this. Other things that I would sort of ask trainees to think about, was there anything in the family history that I was excited about? Father died in his 40s, mesothelioma. I guess we could think about, like, is there any sort of compressive issue? We've really anchored on, this whole being vascular, but you could certainly have some other sort of compressive etiology that's causing, impingement of the subclavian. And if he's a smoker, maybe, he's got a new Panco's tumor hanging out there. So those are other things that would come up. Can we put this into neoplastic? I still to this day use the vitamins mnemonic. So we've talked a lot about vascular infection. It's not really giving a subacute tempo to me. There's no fever, chills, white count. Like I'm not getting that. T trauma. We didn't get any report, but we want to ask, like, was there anything that, like, did you dissect an artery at any point? Did you fall when you were cattle ranching? When we think about A for autoimmune, again, he's not the right demographic for that. M, malignancy, we've sort of said, like, can we put a tumor there? I, idiopathic, we won't really get an answer there. And then N, neoplasm. I think M actually might be metabolic, but either way, I don't think he's a metabolic kind of guy. So, that's more of a child thing. So that's sort of what I'm thinking of. Right now, I've moved from the anterior circulation to the posterior circulation, and I'm really interested in what this guy's subclavians look like, even though it would be a little atypical to be on the right side.
I love your breakdown of the anatomy, like just off the top of your head. And I was wondering, if you were to hear this story and you were triaging this patient, what would you do next? Would you send them to the ER? Is this a stroke alert, or what do you recommend we do on the medicine side?
Oh, absolutely. Like if I hear, painless vision loss acutely in someone who's got vascular risk factors, that is a stroke until proven otherwise. And I think here, where I practice, I think we have a wonderful neuro-ophthalmology group that would really advocate for us treating this like a stroke. And so I think if he's in the 4.5 hour window, I would be considering, if these symptoms haven't resolved, TNK. And again, like I think if we saw something that was, not necessarily an embolic phenomenon, but an occlusive phenomenon, I might feel differently about that. But I would certainly think, like this needs to be treated like a stroke alert.
Awesome. Thank you so much. Back to you, Sean.
Excellent discussion so far. We'll go into our next aliquot, starting with our physical exam. With our vitals, T max was 36.9, heart rate 65, blood pressure 181/89. General, he was well appearing, he was alert, no acute distress, normal work of breathing, cardiovascular, regular rate and rhythm, no murmurs. Feeling his left upper extremity radial pulse, it was 2+. Feeling his right upper, it was undetectable by palpation. Lower extremity pulses were all 2+ as well bilaterally. Mental status, he's alert, no dysarthria, no aphasia, following commands. For cranial nerves, with the right eye, the right upper and lower quadrants were unable to detect any hand motion, count fingers, lights. Left eye, right upper and lower, also the same. There was, I think, a little bit worse midline on the right eye than the left eye, but essentially in both eyes, unable to see the right half of space. Pupils were equal, reactive, there's no APDs, extraocular movements were unremarkable. There was no facial droop. Hearing, he did have baseline decreased hearing just due to his occupation. Palates elevated, midline shoulder shrug was totally intact, tongue protruded midline. For motor, he was actually in the initial exam, I would say 5 out of 5 strength throughout both arms, both legs. However, when you look closely at the bulk, you could notice that in the right upper extremity, his forearm muscles and the intrinsic muscles of the hand were very, very atrophied, especially the dorsolalumbricals and the thenar eminence of that right upper extremity hand. And the more that we started to work with him, the more the pain and the tingling started to develop, and the less able he was able the less able he was to participate with strength testing after just a couple of minutes. And then when he rested it, it came back. Also, while testing the right upper extremity, the skin of the distal fingers and hand progressively lost their color and became very pale. Sensory, intact to light touch, sharps, vibration in all extremities. Coordination, there was no ataxia in the upper or lower extremities. Finger follow was normal. For reflexes, other than his right patellar, which was 3+, everything was 2+. To the hammer, plantar was down going toes bilaterally. Hoffman's were negative bilaterally. Overall, going through his, taking this into a stroke scale perspective, I gave him a stroke scale of 2 for the homonymous hemianopsia. And that's the end of this aliquot. Got it.
Okay, so this is exciting. We are definitely feeling like there's an occlusive phenomenon about this. What I'm struggling with is so it's a right homonymous hemianopia, right? Like the right side is out, which we typically localize to the left occipital lobe. And what's funny about that is then we're saying that his right arm is the one that's weak and doesn't seem to get blood flow. Is that right? Am I remembering this all correctly?
The right arm and yes, the right arm and the right vision, correct.
Yeah, so that's a little weird. Like, and I'm trying to figure out how we can put these together because I really want to tie this in as a vascular phenomenon. I mean, it sounds like the more you're working the arm, the more that there is a steal phenomenon, and that he has certainly lost pulses there. Which amazing that someone checked that. Like, I will tell a story from when I was a resident, and so when you are a PGY2, where I was a resident, and PGY3, you take night crawl alone at one of the hospitals. And then all of the senior neurologists in the morning come to this conference, and you have to tell about what you did overnight. And people just basically friendly and give you a lot of directed feedback about what you may or may not have done well. And I described someone who had a carotid occlusion, and a very senior, very eminent neurologist, and was like, and did they have a bruit? I'm like, sir, I don't know. I did not listen to see whether or not there was a neck bruit. I don't know how to listen for that. And I'm sitting there thinking, I visually auscultated with the CTA I got them. I did not listen for their bruit. So all that to say, props that we did the great physical exam, and that we actually said that, hey, there's not a pulse in this guy. That's props. All right, so the right side does not seem to have a pulse, which would go back to the sort of occlusive phenomenon. But he has a right homonymous hemianopia, which would typically localize to retrograde flow from the left. Now, granted, the left vertebral artery and the right vertebral artery come together in the basilar. And so if you have an embolic phenomenon from a very nasty occlusion somewhere, as long as it's before the vertebral artery, which we think that it is because he's stealing from that side, it is quite possible, I guess, that something in one of the non-stealing moments when his ipsilateral carotid is flowing antegrade brings a little embolic particle up to the basilar, and then it lodges in the contralateral side. So I guess we could have an embolic phenomenon causing him to have this right homonymous hemianopia where he's missing vision. But it is a little strange, and I'm having a hard time thinking about, does he have some different takeoff and abnormal, is there something unusual about his great vessels that would allow us access so that we can more eloquently tie these two together? And off the top of my head, I can't think of a way to do that, but I feel like there might be some way to tie this together, and I just don't spend enough time in the neuro-IR suite looking at all the sort of strange variants of aortic arches and the takeoff. But that would be the one sort of hitch in tying this nicely as a typical subclavian steal, is that I would expect his homonymous hemianopia to be on the same side or the opposite side from where the hand is, so that you would have a right hand weakness, and then right occipital lobe is being deprived of blood, and so you have a left homonymous hemianopia. So Sean's shaking his head yes, we also felt like this was a little bit weird. Other things that I'm thinking of, I mean, now I feel like it's like irrefutable that this is like something is wrong with this guy's vascular flow to his hand. Can we put it in a tumor? Still could put something in compressive. It's weird that it comes and goes. I feel like it's really more like, you know, these like tiny clots, although other compressive things, like maybe, especially as he moves the arm. Was there any way that this like was moving his hand in such a way that seemed to provoke this, like if he moved it up and down, or if he was just like squeezing his hand, anything that really caused this to?
I think really kind of like shoulder abduction up,
Huh.
anything more than just, horizontal would really seem to set it off. But like bigger muscle, the bigger the muscle was, the bigger the movement. That's really what made it worse.
Yeah. Got it. So we're still thinking demand is really what takes us on, instead of maybe like positioning something that would occlude it in sort of the way that his arm was being held. What other things? Again, I don't really love this for like an inflammatory vascular problem. This really does feel to me like atherosclerosis. Very strange, and I'm having a hard time putting it together without evoking that he's got an embolic phenomenon as well. All right.
Thank you so much. And I like your differential. It's like vascular abnormality, compression, embolic phenomena. And before Sean tells us if there was a Brewy or not, I was wondering if just to explain to us how you use the NIH stroke scale. I know you use it like every day, but like how would you explain it to people not in neurology and how you use it?
Sure. Me or Sean?
Whoever wants to.
Sean, you want to take this one?
Sure. So the idea is, you could really go ham on a neurologic exam. You could take 45 minutes to an hour and get every little detail, but that's not really the best thing to do, especially when the question is there an acute change that could be a stroke whose treatment only gets less efficacious minute by minute, right? So there's this NIH stroke scale, which is a very standardized and much more, targeted physical exam designed to go through many common stroke symptoms, give them different kind of designations and quotes, and at the end spit out a number, which in theory should represent the severity of the stroke. There's some asterisks to that, but at least in one person can give you sort of time by time how things are getting better, how things are getting worse. And so, for this person had a stroke scale of 2, which, 2 out of the grand scheme of things isn't always the highest number, but it doesn't necessarily mean that this is not a debilitating stroke. Obviously, when you lose half of your vision, that could be extremely disabling for somebody.
Absolutely. I really have nothing else to add other than there are some components of it that are a little tricky and take, that you actually do need to go through like the course to be certified, because there are some things that are like, feel like, oh, it's like, there are little oddities of it. But I love that the consistency of like you and I examine it and we should be able to get the same thing. And that, helps us if someone is coming from, a rural stroke center to the comprehensive stroke center, are they getting better, worse, the same? That really helps us to chart over time, what they look like, knowing that people fluctuate, and doesn't necessarily mean their stroke has gotten worse. It could just be like they're the middle of the night. And so I do really like that, it's quick, it's efficient. It really undermines posterior circulation. So I think one of the downsides of the NIH stroke scale is, we are much more focused on anterior circulation, like speech, like hand function, and something that is very debilitating. Just as Sean said, like this guy lost half of his vision. That's terrible. That's only going to get you 2 on the stroke scale, and that still is a disabling stroke. And so again, I think it just undermines, especially when we think about like vertiginous symptoms like ataxia and sort of vertigo, like you don't get a lot of points for that, but that could also be disabling and could be the sign of a posterior circulation stroke. So heavily weighted to anterior circulation and to language.
Thank you both so much. And Sean, what did your team do at this point, and what happened next?
Okay, so the next segment, we have our initial labs and some of the initial imaging. So on our basic metabolic panel, we have sodium 136, potassium 3.8. chloride 102, bicarb 25. The B1 was 10, creatinine 0.73, glucose was 124. On his CBC, hemoglobin was 15.7, platelets 148, white cells 7.7, MCV was 90. For his coags, the PT was 11.6, PTT was 30.8. For the extended metabolic panel, he had AST, ALT, and ALK-Phos, and bilirubin, all within normal limits. Next, his TSH was 1.64, A1C 5.7. On the lipid panel, he had an LDL of 129. He had a troponin, a high sensitivity troponin of 6. Next, he had an initial CT head non-con. There was some motion artifact, but it did not note any intracranial abnormalities. He also had a basic chest x-ray and the lungs were clear. However, it did note he seemed to have a cervical rib. And that's the end of this aliquot.
Where was the cervical rib? Like what side?
Yeah. So I believe it was bilateral. They only mentioned it on the right side, but looking at it, I believe it was bilateral.
So nothing here. I mean, the troponin sensitivity of 6 doesn't really make me excited. Everything else is like fairly unremarkable. His hemoglobin A1C is, a little higher than we would have liked, but certainly not in the range where we're like very concerned about like, oh, this guy's got like horrible vasculature versus like terribly controlled diabetes. I mean, it's still less than 6, and so we are even further away from prediabetes. So maybe a little bit higher than optimal, but certainly not bad. Yeah, nothing other than this cervical rib, which I'm sort of wondering, is there any way that this could be compressive? It's a little weird that it's on both sides, but again, the right side is the one that we are most concerned about in terms of like what could be potentially compressing versus to be occluded, causing him from the subclavian artery down to not get blood into that right hand. So it's a little strange. I would say it's a little suspicious without seeing the vasculature, but I think obviously the big question is like, and what proximity is this? And then is there anything else that would explain the vasculature? We don't see any big smoking tumor there.
Yeah, I don't think we got a lot of more information here. It's and I know it's maybe we're trying to like think about other things that are less common, and it sounds like here the hand symptoms are very localizing, which are making things like vasculitis or migraine less likely, and you're thinking more like vascular abnormalities. And so far, we don't see any inflammatory symptoms so far as history. So I think Sean, back to you. And Sean, will the next aliquot reveal the diagnosis?
Pretty much, yeah. Yeah. So this next aliquot, we'll talk about the CTA. I know you're all wondering, did Sean really bring a cattle rancher with a bovine aorta? Unfortunately not. I know you were thinking about, could he have atypical vasculature? So no, his was typical other than the cervical rib. But here's the CTA, and this is kind of combining the head, neck, and kind of below the neck as well. Possible occlusion in the distal left PCA. The right vertebral artery starts from the right subclavian artery. There is an occlusion of the right subclavian artery distal to the origin of the severely stenotic thyrocervical trunk. The axillary artery is reconstituted by retrograde flow within the pectoralis branches of the thoracoacromial trunk. The distal brachial artery is also occluded. Its distalmost portion is reconstituted via branches of profunda brachialis artery. The radial artery is occluded near its origin. The ulnar and interosseous arteries serve flow to the wrist and the hand. Next, we also have the MRI, which is consistent with acute infarcts in the right cerebellar hemisphere, the left paramedian occipital lobe, the right mesial temporal lobe, and an additional punctate infarct in the left thalamus. And that is that aliquot.
Wow. Okay, so I'm gonna have to confess that I do not know where all of these blood branches are. Like, I don't think I've ever heard of this. There was something that was like, there's one that I was like, I've never even heard of this blood branch. Yeah. So this is a little strange because what I think I heard, and again, I have to like see this all written down in the CTA report. I feel like this is one that you'd have to like pull up and then find all the like spots and like where the branches are. But so it sounds like there is occlusion distal to the takeoff of the right vertebral.
Distal to, yes.
Okay, and then on the left, was there anything occlusive on the left side?
You mean below the neck? No.
Yeah, below the neck. Okay.
No.
So we're left with, and was there anything more proximally suspicious before the vert?
In the innominate, there was not, and nothing in the heart, nothing in kind of the aortic arch. No, it was really that piece in that subclavian.
Yeah, so we have subclavian steel, and then we're sort of left with like, how did it get there? Was this a very large clot? Because something had to go up one of the verts. Now, again, the verts, they come together to form the basilar, and then they can go, spread their separate ways at the top of the basilar to the PCA. And so you can have something from one side go to the other side. I will tell you that when we look at injections of contrast in people on ECMO, I actually have a tutorial about this if someone like wants to like dig it back up. But if we inject contrast on one side, remember that ECMO circulation is very different, and sometimes based on where the cannulations occur, one side might be getting blood flow directly from the machine and the other is getting pumped from the native heart. So what you could end up seeing is that the contrast intensities are very different based on whether you're getting blood flow from the machine of the ECMO or from the native circulation. And what you can see, I have a really cool picture of this somewhere, and we'll have to go track it down for the show notes, but that the right flow comes up the vert, they meet with the basilar, and they like pretty much stay separate. So it's pretty cool. I don't think that it says that it's never possible from like one side of the, they going up the right vert can't get you to the left PCA, but it's pretty cool in the ECMO picture that like the right stuff stays on the, like the right blood from the right vertebral stays on the right side of the basilar, goes to the right PCA, the large amount of time. So now we're stuck with something got from one of the verts up to the left, and then the rest of this got into the right side, and it sounds like there's a very gnarly clot. Did we hear, Sean, was there any sort of like, there's a lot of calcification on the aorta, like the whole subclavian is calcified, that would let us think that this was in situ rupture of athero versus like, oh my gosh, this guy has a gigantic cardioembolic phenomenon of like a massive ventricular thrombus just embolized into his right subclavian?
Good question. In the report, there was not, on my own review, at least in the aortic arch and so forth, not terrible calcification, anything like that. No other like, kind of atheromas or things that I could appreciate. No, the biggest thing potentially could have been just compression from that cervical rib onto the artery itself.
Yeah, so fascinating. All right, so we say, so I'm just reading this again. Possible occlusion of just the left PCA. We agreed on that. So we have to have something, a clot that gets into the left PCA, and then we have occlusion of the right subclavian artery. So either something was coming through the aortic branch and goes up to the right. This big clot comes into the right subclavian and it passes, distal to the vert. So the takeoff of the vert is still antegrade, and then goes up to the basilar and then lodges. And these two things happen at the same time. Or he's had this, this right sort of narrowing of the subclavian, and then it gets compressed. And so that's been there for a while. And then it's like too true and unrelated. Like the guy's got clots going everywhere. And then, okay, so then we have the left PCA definitely has strokes, but then we also have the right cerebellar hemisphere. So that's coming off either from the pica territory, often comes off the vert. So we have something that went up the right vert. The superior cerebellar artery and the ICA, they can come off the basilar. So that can be from the basilar from either side of the vert, but the pica territory is usually directly from the vert itself. So we're left to think that something came off the right vert. And then let's see, left permian occipital lobe. Okay, we agreed on that because that's the left PCA. And then right mesial temporal lobe. I think this is a nice thing to remind us that the medial temporal lobe is part of the posterior circulation. Every now and then we find a little clot that I'm just going to silence my phone really quickly because I keep getting lots of notifications. Sorry, guys. First, okay. That we'll see something that involves the medial temporal lobe, and it will be the only thing. I think this is a nice reminder that it's in the posterior circulation. Same thing with the thalamus, which is also part of the posterior circulation. And we're seeing bilaterally. So again, did something come off? It seems more clear to me that something came up the right vert, created some problems in the cerebellum, kind of kept going up the basilar, and then branched to both sides. Do they look all of the same brightness?
More or less, I think the cerebellar one was maybe a little bit more in kind of the late acute to subacute, but overall they were all kind of had the ADC correlate at the time.
Yeah, so they're all kind of showering. So we're having something go up the posterior circulation, and it seems like we want to put this like, something came through the innominate artery, bypassed the carotid, then was in this in the right vertebral, and then had like a problem where it got lodged in the subclavian artery. So now I'm thinking, this could be obviously in situ plaque rupture, that there was some sort of athero process. But now I'm thinking of, do we need to think of like a hypercoagulable problem in someone who maybe has a smoking history? And like, I'm starting to think like, we probably need to do a little bit more evaluation for malignancy. And so I think that would sort of raise my hand in terms of like, what causes this? Common things being common causes of multiple strokes everywhere, AFib, right? Like, I mean, that's just sort of unexciting, but like when we see renal infarcts and clots everywhere, like it just, could be AFib showering. Now, to have a clot lodge in the subclavian, that's a pretty large vessel. So that's going to take a pretty large clot, but it's not impossible. And then we have to think about like what other cause of hypercoagulability. And in someone in this demographic, I think, antiphospholipid syndrome wouldn't be unheard of, but malignancy would be more at the top of my differential as the sort of the two things that cause in situ arterial clot. You can cause a lot of reasons for venous hypercoagulability, but when I think of arterial hypercoagulability, I tend to think malignancy and antiphospholipid syndrome.
Thank you so much. I love your breakdown again, and how you move with the clot and the vessels, and I love how you're thinking about like possible embolic phenomena. Sean, what was your team thinking, and what were like the teaching points you had for us, and what did you learn from this case?
Excellent work. So the story, I actually saw this gentleman at like 3 a.m. And I was actually along the same lines of thinking of you. I was like, oh my gosh, this thing is just distal. I can't explain exactly how. So I was I had ordered this multi-million-dollar workup on this guy because I was convinced there has to be something else going on here. But 3 a.m. I rated to a respectable hour, and then I texted our stroke attending, Dr. Anderson, and I had him look over the case as well. And he gave me some insights onto it that I'll kind of get into a little bit here. So the final diagnosis, as you might all have guessed by now, this is a gentleman who had this 3 months of the intermittent right upper extremity pain, numbness, weakness. There was a lot of atrophy in that arm, as well as more acute onset of right homonymous hemianopsia, likely due, at least in part, to these multifocal posterior territory strokes, which surprisingly was not surprising that he did not have other deficits, at least that I could find. And these in turn are somehow maybe related to this right thoracic outlet syndrome, at least this thrombus sitting in the artery there. So it's possible, right, that some mix of the compression itself caused a thrombus to form, or hypercoagulability, or one of many other risk factors, right? After which it formed, it was clearly an embolic, a very embologenic thing, right? Because we already know he has all these emboli distal in the arm. So then the question is, as you wondered, how did an embolus kind of travel backwards and then up the vertebral, possibly? So the vascular attending I talked to said that one way to think about it is we have essentially an occlusion, right, in that subclavian. Is nothing is really going there, so there's no forward flow through it, and it's only a very short distance away from that, the takeoff of the vertebral artery. So theoretically, you could imagine that in diastole, there could be enough of a pressure drop that the pressure gradient for a little embolus that maybe had formed and had just broken off and is just sitting there in essentially stagnant blood, the pressure gradient could make it go just enough retrograde that in the next systolic cycle, it could be uptaken by the flow and then shot up the vertebral artery. And now, whether this happened multiple times or whether it was one nasty embolus that immediately broke up and got into all of these different parts, we'll never know the answer to that. But we know that this at least is a reasonable mechanism, right, for how this happened. Because the vertebral artery at that point would be kind of the path of least resistance. Other things to think about, obviously, we always try to put everything, at least under, if we can explain everything in one unifying diagnosis, we try to. Sometimes we have to think about 2 separate or 3 separate diagnoses, but at least in this one, I think there's somewhat of a reasonable way to connect the strokes and the right arm here. Some other things, some other teaching points to talk about. Let's see. Talking about the paresthesias he was having in the arm and the weakness that would come. This is, as you mentioned, thoracic outlet syndrome, which, in medical school I learned was mostly just the vascular part of it, but there's really a neurogenic part of it as well. When the compression or the flow to our brachial plexus and the nerves that come off of it is impaired, that's really where we get a lot of the symptoms, less so from, the supply to the muscles itself. So it can cause neurogenic thoracic outlet, can cause numbness, paresthesias, weakness, muscle atrophy over the course of weeks or months. And it tends to be progressive unless the initial course is not corrected. So, and one other teaching point is, in this situation, the thenar atrophy tends to be more affected than the hypothenar. Not that I noticed that at the time, but as far as clinical course goes, he was, seen by us. Obviously, he was outside the window for TNK or TPA or anything like that. He was also very heavily seen by the vascular surgery. So not the neurology, but the vascular surgery for the rest of the body. I believe that they had done where is it here? We started heparin. They started heparin rather. Within a few days, he had some small improvement in his vision, though very incomplete. He had a little bit more ability to move that arm. Several days later, after that, they performed a limited right brachial artery thrombectomy, trying to decrease the thrombus burden for that upper extremity. He was then transferred to rivaroxaban, and next he discharged, but they are planning right now to do a right carotid to axillary artery bypass, hoping that they can at least do something for the arm. And then by that, I guess, hopefully prevent future strokes from happening. But anticoagulation is doing a lot of that role. So yeah,
wow,
you did an excellent job in working through this case.
This is so fun. I always feel like, oh gosh, this is going to be terrifying, but it is really fun that anatomy comes together. And these things that you learn as a medical student, you're like, actually, this was useful. We spend a lot of time, obviously, looking at aortic vessels and arches and subclavians, and but just I feel like that every time I do one of these, it's it really comes together with the localization and the tempo, and sort of the tempo kind of putting us in the realm of part of this had a subacute with the wasting, and then there was another acute component on top of that made us think embolic phenomenon, vascular event. And then the localization, trying to think cleverly of how we can put these together, even though this is sort of an atypical picture. It's really fun.
Yeah, thank you both so much for joining. I think we learned a lot and refreshed on our anatomy and learned about strokes and localizing the lesion. Any closing reflections or anything you want us to take away, Casey?
No, I think It's really just the localization of neurology. I think that that's so different than some of the other branches. Obviously, the physical exam is important in all of medicine, but I'm sure that so many of us come to neurology because of sort of the puzzle pieces of getting to put things together. And it's sort of like, it really feels to me like a puzzle. Remembering that, the arterial hypercoagulability of being either antiphospholipid or malignancy. On the venous side, that's when you start to think of like, a host of other sort of genetic or acquired causes of hypercoagulability. Obviously, notably estrogen and oral contraceptive pills, being one of the main reasons that people develop venous thromboembolic disease or venous sinus thrombosis. But on the arterial side, it's a much more narrow differential. I see that happen a lot for, working up hypercoagulability. And I'm sure there are case reports of anything being possible, but I really tend to think, antiphospholipid malignancy. Other things. No, those are really kind of like the main teaching points that I can.
Yeah, thank you both so much, and we can like tell how passionate you both are about this topic. So it's very nice to learn from you both. We have a big audience here today as well, so we're very grateful for you both. I hope you have a wonderful day. Thank you for joining us on Labor Day, actually, and but because you're joining us to have fun. That's but yeah, have a wonderful evening.
Wonderful,
Thanks,
Sean.
everyone.
That was a wonderful presentation. I loved it.
Thank you. Thank you. You were wonderful as well. And thanks
This was so
everyone
fun.
that came out.
This is great. Thanks, everybody.